My name is Kesava Ramakrishnan. I'm a pediatric intensivist trained in the UK and currently working in UAE. Welcome to this video on VA ECMO cannulation strategy in children. You can insert cannulas for VA ECMO by central or peripheral approach. Central cannulation is when the cannulation is done through a sternotomy. Usually, this approach is used in postoperative cardiac surgical patients. The venous cannula is inserted into the right atrium and the arterial cannula into ascending aorta. Surgeons often use the same cannulas used for bypass during the surgery. Some surgeons insert the arterial cannula into a Gore-Tex graft attached end to side to the innominate artery if this was used for antegrade cerebral perfusion during surgery. The main advantage of central cannulation is that bigger cannulas can be implanted, enabling higher ECMO flows. This may be, I emphasize, may be an advantage for myocardial protection. When more blood is sucked into ECMO circuit, there will be less circulating through the heart, reducing the myocardial oxygen demand. In other circumstances, such as sepsis, where there may be vasoplegia, higher than physiological levels of ECMO flow may be required to maintain perfusion pressure. Bigger cannulas will make venous drainage easier and reduce the negative pressure that the ECMO pump has to apply for drainage. This will reduce turbulence and hemolysis at the venous cannula. Higher flows may not always be advantageous, as increasing the ECMO flow increases the afterload to the left ventricle. The arterial cannula can be imagined as a hose pumping flow towards the aortic valve. This increases the afterload and therefore myocardial oxygen demand. If the myocardium is too weak, the left ventricle may not be able to generate enough pressure to overcome the increased afterload. An aortic valve may not open, leading to LV distension and pulmonary edema. This can happen in a significant proportion of patients with severe myocardial failure anyways, but this will be aggravated by higher ECMO flows. In this case, left side decompression may be required. Another advantage of central cannulation is that it allows direct left atrial venting to decompress the left side if required. If the team anticipates the above scenario, the surgeon can insert a vent directly into LA during implantation of cannulas through central approach. Also, with central cannulation, oxygenated blood will be supplied to all parts of the body, including the aortic root, as the cannula is positioned in the ascending aorta. The major disadvantage of central cannulation is that bleeding risk is much more significant compared to peripheral cannulation. Also, the chest is often left open, increasing the risk of infection. As the vessels are directly accessed, cannulas are inserted at most a few millimeters to 1 or 2 centimeters into the vessels. Hence, there may be a higher risk of cannular dislodgement. Often clinicians use deeper sedation plus or minus paralysis when central approach is used for the perceived risk of accidental decannulation. Another disadvantage is that in the case of ECPR, central cannulation risks frequent interruptions in CPR. Two common sites used for peripheral cannulation are the neck and the groin. In the neck, the IJV and the carotid arteries are cannulated. The venous cannula is positioned in the RA through the internal jugular vein. The arterial cannula is placed in the innominate artery through the carotid artery. In children below 10 to 20 kilos, the femoral vessels are not big enough for cannulation. Only after the child is ambulant, femoral vessels grow in size. Hence, the only realistic option for peripheral cannulation in children below 10 to 20 kilos is the neck. For children above 10 to 20 kilos, femoral vessels are a viable alternative to neck cannulation. With femoral cannulation, the venous cannula is placed in the RA through the femoral vein and arterial cannula in the common iliac artery through the femoral artery. It may be preferable to place the arterial and venous cannulas in different limbs. This enables two operators to work at the same time, establishing ECMO flow much quicker. Also, there may be less risk of limb ischemia as the arterial and venous flow will not be compromised together. The main advantages of peripheral cannulation is that it is simpler and may be done surgically or percutaneously. Also, if there is ongoing CPR, there are less interruptions during the cannulation procedure. Compared to central cannulation, there is also less risk of bleeding. As the cannulas are more stable, patients may be managed more awake compared to central cannulation. A major disadvantage is the size of the cannulas that can be inserted. These are usually smaller compared to central cannulation due to the size of the vessels. In some cases, additional drainage cannulas may be required to achieve the flow, the recommended flow. Another disadvantage is that the option of direct LA venting is not there. If there is LV distension leading to pulmonary edema, the left side has to be decompressed by other techniques such as septostomy. A major concern with carotid artery cannulation is that it may increase the risk of stroke. With the femoral artery, the risk of limb ischemia. In addition, in the case of femoral artery cannulation, there is also the risk of upper body hypoxemia, which we will discuss further in later slides. The best approach for VA ECMO in children remains unknown. Which site carries a better prognosis remains a matter of uncertainty. Clinicians have been taking a pragmatic approach as a result. There are some retrospective studies from the ELSO database which we will review now. The first study is by Johnson and colleagues. They looked at the primary VA ECMO runs in the ELSO database from 1989 through to 2013 in children under the age of 18. A total of 22,671 children were included. As you can see from the table, peripheral cannulation through the neck is the most frequent technique used throughout the pediatric age group. Their main outcome measure was a composite of seizure or brain death or ICH, which they termed as neurological injury. They also looked at the ischemic stroke rate. As can be seen from the table, when controlled for other factors which may influence these outcomes, such as age, indication, and severity of illness, the cannula site did not matter. The next study is by De Gennaro and colleagues. They have diced the ELSO data in a slightly different way to tease out the additional risk of stroke with carotid artery cannulation. The inclusion criteria are narrower. Only patients who receive VA ECMO through peripheral cannulation, that is either carotid or femoral cannulation, were included. They excluded children under 5 as realistically there are no alternatives to carotid cannulation in this age group. They also excluded patients with age above 40 as these patients may have atherosclerotic vascular disease, increasing the risk of stroke. As can be seen from the pie chart, the risk of infarct was 4.4% in the entire cohort. Interestingly, this risk did not change over the years as can be seen from the table. The proportion of patients cannulated through the carotid artery was highest in the 6 to 10 years age group at around 70 to 80%. This decreased with age as can be anticipated. Another interesting trend is that over the years there was a shift towards more femoral artery cannulation in all age groups. In multivariate analysis, they found that the risk of stroke was higher in carotid artery cannulation with an estimated odds ratio of 4. With carotid cannulation, the risk of stroke was 7.3% versus 3.1% in femoral cannulation. This was statistically significant. Interestingly, the risk did not change between the age groups. No difference was found in the risk of intracranial hemorrhage between the cannulation sites. The study did not look into limb ischemia, which is a common complication of femoral cannulation. Clinicians require this information to decide on the risk benefits of different cannulation sites. Maybe someone is already looking into it. Fingers crossed. In summary, which strategy for cannulation offers the best outcome in children requiring VA ECMO is unclear at present. Neck cannulation is a viable option throughout the pediatric age group. Now we will look at some risks specific to femoral artery cannulation. One such risk is upper body hypoxemia. As we discussed before, the femoral artery cannula is placed in the common iliac artery and pumps oxygenated blood retrograde to the upper body. Many patients on VA ECMO can have significant lung dysfunction, for example, due to pulmonary edema and so on. Gas exchange in the lungs may be severely impaired, especially if rest setting is used, which may promote atelectasis. Even on high ECMO flows, a small proportion of cardiac output goes through the heart, especially if the heart can eject. Blood returning to the left side, in this case, is poorly oxygenated due to lung dysfunction and will be pumped into aorta. This blood can preferentially flow to the coronaries and brain, impairing oxygen delivery to vital organs. ECMO team needs to be aware of this possibility and monitor for it. For example, a saturation probe may be applied in the right upper limb, or a NIRS near-infrared spectrometry monitor may be applied to the head, looking for desaturation. Blood pumped by the heart will mix with the blood pumped by the ECMO, forming a mixing zone, pointed by the arrow in this slide. Where this meeting zone will be is dependent on the native cardiac output versus ECMO flow. If the heart is hardly ejecting, as shown in the image labeled cardiac function 0, the risk of upper body hypoxemia is low. As the cardiac function improves, the deoxygenated blood can reach the root of aorta and coronaries and subsequently the brain. If this happened, you could recruit and ventilate the lungs a bit more, improving lung function. If the lung function cannot be improved, you can add a return cannula to the venous side and run a hybrid mode of VAV ECMO. It is important to recognize that femoral artery is an end artery, therefore femoral cannulation can lead to limb ischemia. Also, the venous cannula can obstruct the venous return, which could aggravate this ischemia. Occasionally, even obstruction to venous flow can lead to limb ischemia on its own right. Patients may end up with compartment syndrome or amputation. The incidence of limb ischemia is higher in pediatric patients, as can be anticipated due to the smaller size of the vessels. Some centers routinely insert a retrograde perfusion cannula as illustrated in this image. If time permits, a wire can be inserted distal to the proposed cannulation site to facilitate insertion of the distal perfusion cannula later. This may make it easier as the vessels often collapse after the cannulation, after the ECMO cannulas are in place. Some centers take a joint approach between interventional radiologists and surgeons to place distal perfusion cannula if the limb ischemia develops after cannulation. The arterial return is split to supply the distal perfusion cannula. Usually, the distal perfusion cannula and the supply tubing is smaller in size, limiting the flow, preventing stealing too much of ECMO flow from the rest of the body. Another approach taken to prevent limb ischemia is to use an end-to-side graft to the femoral artery. The return cannula is positioned in this graft, and the blood supply then goes both towards the upper body and distally in the limb. The major disadvantage of this technique is that it takes time, hence it's not a preferred approach in situations such as ECPR. In rare cases, if a distal perfusion cannula could not be inserted for whatever reason, distal arteries such as posterior tibial artery can be cannulated for retrograde perfusion of the limb. This may not be an option in small children due to the size of the vessels. In summary, both central and peripheral cannulation can be used for VA ECMO in children. Central cannulation is most frequently used in post-cardiotomy patients. Peripheral cannulation is often used in non-cardiotomy patients for pragmatic reasons. In children less than 10 to 20 kilos, neck cannulation is the most realistic option for peripheral cannulation. In children above this size, femoral cannulation becomes an option. Each sites have their advantages and disadvantages. Thank you.